Let's begin with the definition. Preterm labour is defined as regular contractions causing cervical change at less than 37 weeks gestation with intact membranes. Next, let's discuss the immediate delivery indications. These include maternal instability, intrauterine infection, and fetal distress or demise. Now, let's move on to management by gestational age. First, for patients at less than 32 weeks gestation, which is considered very preterm, they require antenatal corticosteroids such as betamethasone to promote fetal lung maturity and decrease the risk of neonatal respiratory distress syndrome. Penicillin is needed if Group B streptococcus is positive or unknown to prevent vertical transmission of the infection. Tocolysis with Indomethacin is used to inhibit contractions and delay delivery. Note that there is a risk of fetal oligohydramnios and premature closure of the ductus arteriosus, so it is typically given for 48 hours or less. Magnesium sulfate is administered for fetal neuroprotection to reduce the risk of cerebral palsy. Next, for patients at 32 to 34 weeks gestation, considered moderate preterm, they also require antenatal corticosteroids to promote fetal lung maturity and penicillin if Group B streptococcus is positive or unknown. Tocolysis with Nifedipine is preferred over Indomethacin due to lower fetal risks at this gestational age. Moving on to patients at 34 to 37 weeks gestation, considered late preterm. Antenatal corticosteroids may be administered to decrease the risk of neonatal respiratory distress syndrome, though their use after 34 weeks is not universal. Penicillin is required if Group B streptococcus is positive or unknown. Expectant labour management is typically appropriate, and tocolytic agents like Indomethacin and Nifedipine are not recommended due to the outweighing risks compared to the neonatal risks of preterm delivery. Now let's consider the risks and considerations. Indomethacin tocolysis carries the risk of fetal oligohydramnios and premature closure of the ductus arteriosus. The risk increases with prolonged administration, and it is typically used for 48 hours or less. Nifedipine tocolysis poses risks, including maternal hypertension and tachycardia, which outweigh the benefits at 34 weeks gestation or later. Finally, special notes. Group B streptococcus prophylaxis is necessary for all preterm labour patients with unknown or positive GBS status to decrease the risk of neonatal infection. Neuroprotection with magnesium sulfate is indicated for patients less than 32 weeks gestation to reduce the risk of cerebral palsy. It is not typically used at 32 weeks gestation or later due to limited efficacy data at later gestations. By structuring preterm labour management based on gestational age and associated risks, healthcare providers can ensure appropriate interventions are implemented to optimise both maternal and neonatal outcomes.